Arkansas has not been hit as hard as a lot of states by COVID-19. Population accounts for some of that. What do you attribute to the fact that it has not been as bad here? Not to discount what has happened, but it has not been as bad here as other hot spots around the country or even some neighboring states.
Well, Roby, as you mentioned, we have a lower population density, a smaller population. We don't have as much international travel as some other states, and so those helped us. I think we've also had some very good decision making by the governor. He has really used the data to drive our decision making and has had a cautious but clear approach. But I also would say what I'm most happy with is that our deaths per population have been really low compared to many other states, and part of that has been a very aggressive approach to protecting the most vulnerable, particularly those who are in nursing homes.
We do have a lot of outbreaks in nursing homes, so don't want to discount that. I think 50 nursing homes have had outbreaks. There's been some other congregate centers too where we've seen some things happen. The prisons are obviously one of those places. What's the end game to make those places safe? How do you get them beyond the illnesses that are in there and get them to the place where it actually may be safer to be in one of those places?
It's a very good question. I don't know that anyone has the answer for that. I mean, part of the answer is that it's really very, very difficult to protect your most vulnerable as long as you have lots of transmission in the community. I think a lot of people pointed to the example of Sweden, where they had a strategy where they would really not be concerned about transmission in the community, but try and protect the most vulnerable. Well, I don't think that strategy really works very well, and I'm not sure it's working very well for them, because it's impossible to protect the most vulnerable if you have a lot of COVID-19 activity outside of those settings.
Did luck play a little bit of part in us not getting hit as hard as some other places? I mean, we didn't have a Mardi Gras, we didn't have a spring break, we don't have that population density. Was some of it just blind luck?
I guess you could call it whatever you want. Divine providence is probably what I would prefer to say.
Okay. Senator Rand Paul testified on Tuesday that he suggested schools could open this fall because children are not becoming as infected with this as older people in the population have been. First of all, do you kind of share that sentiment, number one? And two, what are going to be the conditions for in-person education this fall?
Well, the latter part of your question, I think the governor has made it clear, and I think many other governors as well, that the intention is that we would have an in-class school year starting in the fall, and I really hope that that is possible. I think we will all work very hard to make that possible. Now, the first part of your question was, are kids immune to COVID-19? Not really. Fortunately, they are less likely to become severely ill, but as we have learned from the experience in New York and some other places, there are some complications from COVID-19 that can very adversely affect children. And so we want to protect our children, but also in a school setting, it's not just children, it's their teachers. And many of our school teachers have risk factors. And then it's their families when they come home, and it's grandparents, etc. So we are a highly integrated society, and I don't think it's possible to just say, let COVID-19 run loose in this sector and then hope that we can protect others.
I think a lot of people, and I see this in the press conferences, I have these same thoughts too. We want to pin you down on what is going to be the environment to allow some of these things to happen. And that's probably a little bit of I'll know it when I see it kind of attitude in terms of looking at the data and understanding. Is that a fair assessment, or is there something a little bit more structured in the decision making?
Right. The best response to many of these settings is highly contextual. By that I mean we got to see what the situation is, what the best choices are, and our knowledge, our understanding of this virus is emerging very quickly. Remember, this was not really even known until the very end of December. Really wasn't identified until the first part of this year, and it seems like an eternity, but it's only May.
It's too late to reopen schools this year, and that decision was made a few weeks ago. But if you're looking at the environment we have now as we're reopening businesses and other parts of Arkansas, if the circumstances were like they are right now this fall, would you have confidence in opening up the schools for in-person education?
I think things would have to be different before I would be comfortable opening schools, but I could see a variety of scenarios. We have seen a general downward trend, both in terms of new cases and hospitalizations, and over the course of the summer we're able to sort of wrangle this epidemic in Arkansas down to the ground to where we have a very, very low case numbers. Then I think that going to school and being highly vigilant, if we had an outbreak, jumping on it quickly with our case investigations and contact tracing, I think that would be one option. Another option was to scale up our testing to such a point that we can basically be screening people often enough to know who's positive and who's negative. If there's no one who's infected, then it doesn't really matter what you do in terms of social distancing, you're going to be okay. But to have that testing capability to where you could know that for sure, that's not where we are now, but it could be where we are in the fall.
I want to come back to testing and contact tracing a little bit later, but another question first. In this reopening of Arkansas for business, what was the pivotal juncture for you to feel like it was time to do that? There's a set of data points that you're looking at. There's some reality of we've got to get the economy moving again. What kind of tipped you past the point of it's okay for us to take a little bit of the foot off the gas pedal on the restrictions on this?
Well, for me, in terms of that decision, it was a very complicated decision. There's a lot of factors involved. I know it was a tough decision for the governor to make. When are we going to start moving forward? But as you pointed out, we can't stay in lockdown forever. You know, once we run out of financial resources, no one has a job, no one has any money, we can't protect anyone from anything, let alone COVID-19. On the other hand, we had gotten a lot of positive benefit over the things that we did. We really were able to bend the curve. None of the dire predictions from the predictive models really came true in terms of surge, hospital capacity, ventilators, things like that. So we knew we were going to be okay from that standpoint. And so the question is, can you completely get rid of it with the things that we were doing? Not likely in a state like Arkansas, where we've got surrounding states that all have at least as high or higher case per population. So when is it safe to start moving in that direction? Once we saw the number of cases coming down, the president's opening up America again, gating criteria, meeting those were all things that were telling us we were heading in a direction where it was safe to start reopening and watching carefully.
What was the gating criteria? It wasn't the 14-day downward trajectory, because we've not had 14 days of moving downward with our caseloads. What was the gating criteria?
Well, the gating criteria are threefold. The first one had to do with symptoms, and COVID-like symptoms. That was a 14-day, more than 14-day downward trend. Also, there's a system called ILI-Net, Influenza-Like Illness Network, which we used during flu season, and we did see a downward trend on that one as well. So that was the first criteria. The second one was cases, and there was a 14-day downward trend in cases, which we eventually did meet, but also a downward trend, 14-day downward trend in the percent positive tests, and we clearly met that one. It was an either or on that criteria. And then the third criteria had to do with hospital capacity, and we were never close to our maximum hospital capacity.
Well, was it always about making sure that we didn't overwhelm the hospital resources? That has been an argument that some people have made, is we weren't doing this to eliminate the coronavirus. It was going to be in our communities and in our system no matter what. The goal originally with the lockdown was to keep the hospital system from being overwhelmed. Was that what was driving policy at that time, or was there more than that?
Well, that has always been an important policy objective, both nationally and here in Arkansas as well. And it's important because in settings where they have overwhelmed the healthcare system, the number of deaths and people injured is not just those who have COVID-19, but those who had treatable conditions who couldn't get care because they couldn't get into a hospital, or they were afraid to go to the hospital because they were afraid of getting COVID-19. And that's still very much a real part of our policy objectives, is to get our healthcare system back up and running. There are still people I know who are reluctant to go to the doctor or go to the hospital because they're afraid of COVID-19. I mentioned yesterday that my in-laws were concerned about going to a needed clinic visit because of that, and we just had a conversation, and fortunately they went, and my father-in-law got the care that he needed. But I think a lot of people have those concerns. But it's not the only policy objective. Obviously, I'm equally concerned about saving people's lives, not just not overwhelming our healthcare system. So it's a both and. In public health, we oftentimes have to do more than one thing at one time.
Was there any political pressure to restart the economy, to reopen the economy? Was this you coming to the governor and saying it's time to do this, or was this the governor coming to you and saying, Nate, when is the time to do this?
This has been an ongoing conversation between me and the governor from the beginning, and I understand that public health isn't just about health care. It's about people's entire environment they live in. We sometimes call that the social determinants of health. Right. And I will guarantee you that there'll be more people who die this year in Arkansas from conditions that are more closely tied to their socioeconomic status than to COVID-19.
Obesity, diabetes, heart failure, things like that.
Exactly. We are very, very interrelated between our economy, education, and health. It's really not possible to achieve optimal health for all without a strong and healthy economy and a good educational system.
Let's move back to testing that we talked about earlier. We've laid out some goals for where we're going to try to get with testing. You've got the 60,000 mark that you guys have put out there. I think you've got 90,000 new test kits. That number may have changed. What's the best we're going to get in terms of testing in Arkansas? And we're not alone in this. Every state's struggling, but what's the highest percentage of what we're going to be able to test? And what would you prefer we be able to do if there was no limitation on those resources?
Well, I think we're going to be able to achieve a lot more in terms of testing. Quite honestly, now anyone who needs a complete blood cell count or a Chem7, can go into the hospital or go into a clinic and they can get that test done. The testing for COVID-19 is no more complicated. And so we will get there, I am confident. In fact, we will probably, just the way markets work, we'll probably overshoot where there'll be eventually more supply than demand.
Yeah. But how quickly will that, what's that window that you're looking at for that?
The testing capacity is growing very, very rapidly. Most of it is occurring in the commercial labs, and they will scale up according to demand. They're not going to overbuild intentionally, but right now we have some pretty rapid turnaround times from a number of our commercial labs, 24, 48 hours. I know at the Arkansas Department of Health, we have scaled up. We hit over 300 tests in a 24-hour period on Friday, which is much more than what we started with. We started out with a capacity of about 5 or 10 a day.
And is that because you found the supplies, the reagents, the kits, the swabs, the supplies that you've needed for that, or the manpower?
All of those together, and it's kind of like baking a cake. There's lots of ingredients, and if you're missing one, it's not going to turn out. And so we have basically had people doing testing 24/7 around the clock, and that's dependent on a supply of reagents. It's dependent on people who are trained and able and willing to work those long hours, and then also dependent on having people collecting the specimens and getting them into us in a timely fashion. We are expecting a high throughput machine, though, which will allow us to do all of this in an automated fashion, much more testing, much more quickly with fewer individuals, and most importantly for our lab, less space. There's only so many people that you can fit into a laboratory and do it safely.
Yeah. What's the time frame on that? How quickly might we see us reach this level of, I don't want to call it oversupply, but where we are certainly easily meeting the demand?
Well, currently, we have more testing capacity, if you include the commercial labs, than we are having demand. And that's why today when I was in our media briefing, I was saying, we need to get out there. If you have symptoms or if you've been in contact with someone who's tested positive, you need to come in and get tested, because we have more testing capacity than we're actually having people tested. Now, to get up to the point where we're testing every school child, for example, before they go to school, or everyone before they go to work, or whatever, that's a different level, and we're not there yet.
You think we'll get there?
If we have to, we will.
Yep. All right. Let's talk about contact tracing. What's our capability today? Where do we need to get?
We have really ramped up our ability to do contact tracing in Arkansas. We have over 200 people assigned to that task, but we are not where we need to be, where we will need to be in the future. What I think a lot of the people in the general public don't realize, when we talk about contact tracing and case investigation, we're really talking about kind of like each case is like solving a crime. I think many of us like these criminal justice shows and the detective. So that's kind of what each case is like. And so it's not something that you put into a machine and you crank the handle. It requires people who have experience and training to get that information, to track down the leads, and to do it fast enough to get ahead of the virus.
Do you think, I'm just going to throw out a scenario here. The casinos are going to eventually reopen here in Arkansas. We may have people from other states. This could also be a state park. It could be a business where there's out-of-state travel. Someone comes here, we determine there's an infection here. It could have strands that go into the dozens, and you can trace all that. You feel confident that we can get every one of those people accounted for with the system that's going to be in place?
Yes, and we're going to have to. That's not that much. It's the same thing that we've done for mumps, for hepatitis A, et cetera. In terms of the mechanics, but with mumps and with hepatitis A, with these other outbreaks that we deal with all the time, we've never had to do 100 cases every day, day after day.
Yeah, I was about to say, this could overwhelm the ability to contact trace on a timely basis. What will you do if you get to that point? Will you ramp up with more manpower, what's the solution?
Exactly. That's what we're needing to do. We have over 200 people, but we need more, and we need people who have experience, who have training, who have the equipment that they need. And just as importantly, we need to have data systems to where we are able to take all these data that we generate and to produce actionable information in a timely fashion, basically connecting the dots.
Do we have that?
We don't have that yet, but we're working towards that. I know the governor is going to make a proposal using some of our federal funding that's available to us as a state to take us to the next level. And if we are able to do that, which I'm confident we will be, it will help us not just for COVID-19, but for all sorts of outbreak investigations that we might have in the future.
Dr. Fauci testified on Tuesday as well before a Senate Health Committee that I think, if I remember this correctly, there's about 8 vaccines that may be in process from different people that are working on vaccines. And he basically said that they all show promise. Would it be a good idea if multiple vaccines came to the market at one time, or is that possible? Is that a possibility that's how that might happen?
It's certainly possible that more than one company may have a successful vaccine. It's also possible that none of them will have a successful vaccine. But if we have multiple vaccines, that I think we're going to need multiple manufacturers to help meet that need. It would probably not be a good thing if our entire strategy for controlling this pandemic were tied to one manufacturer.
Yeah. Is finding a vaccine though, or multiple vaccines, is that the long-term solution to solving this problem? We can't contact trace forever. We can't isolate forever. we can't social distance forever. I mean, maybe we can. Maybe you can. I don't know if I can or not. But is the vaccine the ultimate thing that returns us to some level of normal?
I think vaccines have been transformational in terms of healthcare and in our lifetimes. And we have so many highly effective vaccines that have really changed human existence. And it's frustrating sometimes when there are sort of anti-vaccination messages out there, but things like measles, smallpox, which has been eradicated, many other vaccine-preventable diseases, our lives have been changed fundamentally by the presence of those vaccines, the existence of those vaccines. So that would be our first choice for this. Of course, it was our first choice for HIV, and we still don't have a vaccine there. It would sure be nice to have a highly effective vaccine for malaria or tuberculosis, but we don't have those either. So if we can get a vaccine for COVID-19, that would definitely be the first choice, but there's always the possibility that that will elude us.
What happens? What happens if we aren't able to do that? Just from a public health perspective, what does that change in terms of society?
Well, we'll have to get really, really good at contact tracing and case investigation. You know, that humans have a remarkable ability to adapt and to overcome adversity. And so I'm confident that we will be able to do that. But having a highly effective vaccine that's widely available, that sure would be the easy button for this.
That sounds like that might be a worst case scenario, that we don't come up with a vaccine and we have to continue these mitigation and other policies and procedures that we have in place here. Is it possible that things still in Arkansas could turn negative enough that we have to go back to where we were at the very beginning of this, almost 6-8 weeks ago? Maybe even look at shelter in place. I'm not trying to put words in your mouth, but is that doomsday scenario still a possibility?
I think the governor has said that all options are on the table. If we need them, we would do that. But I don't think it's a very good long-term strategy because we can only sustain it for so long. And when we were getting a lot of pressure here in Arkansas to shelter in place or lockdown, you know, my advice to the governor was, whatever we do, we're going to need to be able to sustain it for at least 8 weeks. You know, this 15-day business and 30-day business, you know, that's not realistic. That's not going to cure it for us. Whatever we do, we're going to have to be able to do it for long enough until it's effective. And I think that's what we've done, and we have gotten over the hump, at least over this wave, and I think that's permitting us to walk back from some of those restrictions.